Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the cardiology, that is the pericardial effusion. So, pericardial effusion, as the name itself tells you, that it is a clinical condition which is characterized by excessive accumulation of the fluid in the pericardial space, is what is called as the pericardial effusion. So, you need to know how much is the normal quantity of the pericardial fluid in the pericardial space. So, the normal quantity of the pericardial fluid in the pericardial space, it is around 20 to 30 ml. And this pericardial fluid, it will reduce the friction between the parietal and visceral pericardium. Right, it will reduce the friction between the parietal and as well as the visceral pericardium. And this pericardial fluid, it also acts as the shock absorber. Right, it also acts as the shock absorber. That is the function of the pericardial fluid. Now, when is that we use the terminology pericardial effusion? So, if you see this question now, what is the minimal quantity of the fluid for using the terminology that is pericardial effusion? The options are 25 ml, more than 50 ml, more than 100 ml, more than 150 ml. So, to call it as pericardial effusion, the quantity of the fluid that should be there in the pericardial space, it should be more than 50 ml. Now, what are the etiologies which will cause the pericardial effusion? So, the fluid, it may accumulate in the pericardial cavity in virtually all forms of the pericardial diseases. So, in the sense, pericarditis is one of the etiology which will cause the pericardial effusion. Then followed by that, in clinical scenarios of overhydration or hypoproteinemia, right? In clinical scenarios of overhydration and hypoproteinemia, even this can cause the development of the pericardial effusion. And another very important clinical scenario that you need to remember is the presence of or the development of or an individual who has acquired any trauma. So accordingly, if you see a question, frank blood in the pericardial space is seen in tuberculosis, chronic renal failure, aortic dissection, neoplastic diseases. So now what is this effusion called as? This is called as the hemorrhagic pericardial effusion. Now where all you will come across this hemorrhagic pericardial effusion, right? Where is that you will have the presence of the frank blood in the pericardial space. So the frank blood in the pericardial space, it is present in cases of aortic aneurysm or the aortic dissection. Right, then followed by that, what is a clinical condition where you have the presence of serosanguinous pericardial fluid? Serosanguinous pericardial fluid is a classical sign in tuberculosis and as well as the neoplastic diseases. Right, neoplastic diseases. So these are the conditions which will cause the presence of the serosanguinous pericardial fluid. Then followed by that, the hemopericardium. What are the clinical conditions where you have the presence of the hemopericardium? Hemopericardium may also be produced by closed or penetrating trauma. right, either by closed or penetrating trauma, and then rupture of the heart in acute MI. So in acute MI, the structural complications that can be seen is the free wall rupture, whichever is the infarcted area that can get ruptured, and thereby the blood from the chambers enter into the pericardial cavity, resulting in hemopericardium, and the bleeding disorders caused by the coagulation defects like hemophilia. So these are the causes for the hemopericardium. Now, followed by that, you need to remember one of the very important endocrine cause for the development of pericardial effusion. And this endocrine cause which will cause pericardial effusion includes it includes hypothyroidism, right? So these are the etiologies which will cause the pericardial effusion, and as well as the presence of the serosanguinous pericardial effusion, frank blood, or your hemopericardium. Frank blood and as well as hemopericardium, more or less both of them are the similar clinical scenarios. Then we have two clinical entities called as pericardial effusion and as well as the cardiac tamponade. What are the differences between the pericardial effusion and cardiac tamponade? See, when the fluid in the pericardial space, if it accumulates slowly, right, the fluid in the pericardial space fluid in the pericardial space, if it accumulates slowly, then the pericardium expands to accommodate it. Right, pericardium expands to accommodate it. That is called as the pericardial effusion, right? When fluid accumulates slowly, the pericardium expands to accommodate it is called pericardial effusion. Whereas in case of cardiac tamponade, the fluid accumulates rapidly. Right, the fluid, it accumulates rapidly in case of the cardiac tamponade, and because of the rapid accumulation, the pericardium or the pericardial space is unable to accumulate the fluid which has come in the cardiac tamponade, and this fluid which has accumulated rapidly, it compresses the heart. Right, it compresses the heart and inhibits the cardiac filling. Right, inhibits the cardiac filling. That is what is called as the cardiac tamponade. So the differences between pericardial effusion and cardiac tamponade is that in case of pericardial effusion, the fluid accumulates slowly, right, and the pericardium expands to accommodate it. Whereas in case of cardiac tamponade, the fluid accumulates rapidly and it compresses the heart and inhibits the cardiac filling. That is called as the cardiac tamponade. So in pericardial effusion and as well as cardiac tamponade, we have many clinical signs that has to be elicited. Now, I will discuss all the clinical signs in pericardial effusion and as well as in cardiac tamponade. So, the first important sign is, what is Friedrich's sign? Sudden collapse in the distended neck veins with diastole, anterior bulging of the lower sternum, protuberance or bulging of the epigastrium, percussible dullness in the left third intercostal space. See, Friedrich's sign, it tells you sudden collapse in the distended neck veins with the diastole. Okay, So it is the sudden collapse in the distended neck veins with diastole is called as the Friedrich sign. And the presence of the Friedrich sign, right, please remember, the presence of the Friedrich sign, it suggests, right, it suggests the presence of pericardial tamponade or cardiac tamponade. Right, it suggests the development of the cardiac tamponade. That is what is your Friedrich sign. Then followed by that we have one more important sign, that is called as the Onbrugger sign. Onbrugger sign is seen in pericardial effusion, constrictive pericarditis, aortic regurgitation, mitral stenosis. Onbrugger sign, it is suggestive of massive pericardial effusion. Right, it is suggestive of the massive pericardial effusion. And what exactly happens in the Onbruggers is, it is the scenario because of the massive pericardial effusion, there will be an epicardial bulge which is seen in the epigastric region, right? So because of the massive pericardial effusion, what is that you will be able to see is the presence of the epicardial bulge. Right, what is that you are able to see? Because of the massive pericardial effusion, the development or the presence of the epicardial bulge due to massive pericardial effusion. Now, if this epicardial bulge, right, so you have an epicardial bulge. So this epicardial bulge, if it is being compressed, right, if this epicardial bulge, if it is being compressed, that will cause the hemodynamic compromise. Right, that will cause the hemodynamic compromise and cardiac tamponade. Right, that will cause the hemodynamic compromise and as well as the cardiac tamponade. That is what is your Onbrugger sign. So Onbrugger sign is that where there is the bulge which is seen in the epigastrium, and that is seen in case of severe pericardial effusion. And whenever you apply the pressure over the epigastric region, right, that is just beneath the xiphoid area, once you apply the pressure over this epicardial bulge, it will increase the pericardial pressure. Actually, why there will be hemodynamic compromise and the development of cardiac tamponade is, whenever you are compressing the epigastric bulge, it is like indirectly increasing the pericardial pressure. Right, it is like indirectly increasing the pericardial pressure. So once there is increase in the pericardial pressure, you will have the clinical scenario similar to that of the cardiac tamponade. So what exactly happens in the hemodynamics of the cardiac tamponade, I have discussed in a separate session of the cardiac tamponade. But please remember, Onbrugger sign, it is suggestive of severe pericardial effusion where you will have the presence of an epigastric bulge, and when you compress that, there is increase in the pericardial pressure that will cause hemodynamic compromise and makes the individual to land up in the cardiac tamponade. That is what is your Onbrugger sign. Then next important question is, or next important sign is the anterior bulging of the lower sternum. It suggests the pericardial effusion. And what is this sign? This sign is Pitrus sign, Sansom sign, Green sign, Epstein sign. Okay. Now let me discuss what is this? This is nothing but your Pitrus sign. Now, what is this particular Pitrus sign? Pitrus sign is anterior bulging of the lower sternum, this will suggest, right, this will suggest the development of the pericardial effusion. Right, this will suggest the development of pericardial effusion. That is what is called as the Pitrus sign. And on Brugger sign, just now I have discussed, it is protuberance or bulging of the epigastrium, and that suggests the massive pericardial effusion. Now, so yes, anterior bulging of the lower sternum suggests pericardial effusion, and that is called Pitrus sign. Now, what about the other sign? Now, what is the Sansom sign then? So, you see this question, Sansom sign in pericardial effusion represent percussible dullness in the right third intercostal space, percussible dullness in the left third intercostal space, percussible dullness in the left second intercostal space, percussible dullness in right second intercostal space. So, now let me discuss about the Sansoms. So, if you take the Sansom sign, first of all you have to understand that the left third intercostal space, right, left third intercostal space, normally you will have resonant note on percussion, because left third intercostal space, it is occupied by the lung. So, you have the presence of the resonant note. But if this left third intercostal space, if it is dull on percussion, right, if it is dull on percussion, that is suggestive of the Sansom sign. Right, left third intercostal space is normally resonant because it is occupied by the lung. But if it is dull on percussion, that is suggestive of the Sansom sign. Then next, coming to the green sign. So, if you take this green sign, it is lateral displacement of the percussed cardiac border. Right, lateral displacement of the percussed cardiac border. See, you have resonant note in major portion of the chest, except over the pericardium, that means except over the place where there is presence of the heart. But if this particular cardiac dullness border, if it is displaced laterally, right, if it is displaced laterally, that is called as the green sign. And why is that cardiac border dullness is displaced laterally? Because of the presence of the pericardial effusion. So, lateral displacement of the percussed cardiac border with expiration, right, with expiration, that suggests the presence of large pericardial effusion. Right, that suggests the presence of large pericardial effusion, and that is what is called as the green sign. So, now if you see the question on the Sansom sign, it is the pericardial effusion, and how is it represented? It is represented by the percussible dullness in the left third intercostal space. That is what is called as the Sansom sign. Alright. Now, then followed by that, we have few more signs to discuss. That is, the question is, a large pericardial effusion can blunt the percussible right cardiomyopathic angle, producing dullness along the lower right sternal border. What is that sign? Pitrus Sign, Sansom Sign, Green Sign, and then the Epstein Sign. Now, the right cardiomyopathic angle, it is dull on percussion, or dullness is present along the lower right sternal border, and that particular sign is suggestive of the Epstein sign, right? That particular sign is the Epstein sign. Now let me discuss in detail about the Epstein sign. So you have, this will be the 4-chambered heart, and this 4-chambered heart, it is present on the diaphragm, and this will be the cardiomyopathic angle, right? So this will be right cardiomyopathic angle, and this right cardiomyopathic angle becomes dull on percussion. Right, there will be dullness on percussion, and that is what is called as the Epstein sign. And even this particular dullness, right, even this particular dullness, it is also present along the lower right sternal border. Right, the dullness is also present along the lower right sternal border. That is what is called as the Epstein sign. Right, Epstein sign, it is nothing but the dullness of the right cardiomyopathic angle, right, percussible dullness. Normally it is a resonant node because it is occupied by the lung. Now after having discussed about the Epstein sign, right, so this will be the right cardiomyopathic angle that will become dull on percussion, and that is what is called as the Epstein sign. Now we have one more sign to discuss, that is called as the Roth sign. Roth sign in pericardial effusion represent, see, in pericardial effusion the transition on percussion from lungs in the right heart border is abrupt. Large pericardial effusion produces egophony and bronchial breathing at the lower border of the left scapula. Dullness at the right lower sternal border suggests the large pericardial effusion. Fourth option, a large pericardial effusion produces egophony and bronchial breathing at the lower border of the right scapula. Now, what is this particular Roth sign? Let me discuss. So, Roth sign, it represents the dullness at the right lower sternal border. It is the dullness at the right, it is dullness at the right lower sternal border, right, and this dullness at the right lower sternal border, that suggests right, that suggests the large pericardial effusion. That is what is called as the Roth sign. Then we have one more sign that is called as the Moshowitz sign. Moshowitz sign is that in pericardial effusion the transition on percussion from lungs in the right heart border is abrupt. Normally the right heart border to that of lungs, transition is not abrupt. Right heart border, it is present in the retrosternal area, that is just behind the sternum. But in case of the pericardial effusion, the dullness, it will displace towards the right side of the sternum. So thereby the transition on percussion from lungs in the right heart border is abrupt. So what is Mosovich sign? It is in pericardial effusion. The transition on percussion from the lungs in the right heart border is abrupt. Right, the transition on percussion from the lungs in the right heart border is abrupt. That is called as the Mosovich sign. So if you see this question now, first thing is Roth sign. What is Roth sign? Dullness at the lower sternal border suggests large pericardial effusion. That is called the Roth sign. Whereas what is Mosovich sign? In pericardial effusion, the transition on percussion from lungs in the right heart border is abrupt. That is called as the Mosovich sign. Now you see another question. A large pericardial effusion produces egophony and bronchial breathing at the lower border of the left scapula. What is this sign? Mosovich sign, IART sign, IART second sound, Dressler sign. So if you see the signs in pericardial effusion, one of the very important signs that we need to discuss is about the IART sign. What is IART sign? See, if there is presence of large pericardial effusion, right, the presence of large pericardial effusion, that will compress the lung parenchyma, right, that will compress the lung parenchyma, and that compressed lung parenchyma will behave as a consolidated lung, right, that compressed lung parenchyma will behave as a consolidated lung. So a large pericardial effusion will produce egophony, right, will produce egophony and bronchial breathing, right, will produce egophony and bronchial breathing at the lower border of left scapula. Right, at the lower border of the left scapula. This is what is called as the IART sign. So whenever there is presence of a pericardial effusion, that will compress the lung parenchyma, and that compressed lung parenchyma will behave as a consolidated lung, and that will produce. So when you auscultate over the consolidated lung, that will behave, or when you auscultate over that consolidated part of the lung because of the compressed pericardial effusion, you will have egophony on auscultation and bronchial breathing, because in consolidated lung you have the egophony and bronchial breathing, and this large pericardial effusion is compressing the lung parenchyma, and that compressed part of the lung parenchyma will behave as a consolidated lung. And what is this egophony? Egophony is that the patient says the word E. You need to put the stet over the lower border of the left scapula, and then you should ask the patient to tell the word E. Now, once the patient tells the word E, you will listen that as Ah, right? You will hear that as Ah. That is what is called as the egophony, right? That is what is called as egophony. Okay, so a large pericardial effusion produces egophony and bronchial breathing at the lower border of the left scapula, and that is called as the EART sign, right? That is what is called as EART sign. Now we have what is called the EART's second sign. EART's second sign in pericardial effusion is, the options are, a large pericardial effusion makes the left first rib seen more prominent along the sternal border. Second option is, a large pericardial effusion makes the right first rib seen more prominent along the sternal border. Third option, a large pericardial effusion makes the left second rib seen more prominent along the sternal border. Fourth option, a large pericardial effusion makes the right second rib seen more prominent along the sternal border. So the question is, what is the EART second sign? So EART second sign is a large pericardial effusion right, a large pericardial effusion. This makes the first rib, right, this makes the first rib seen more prominent along the sternal border. Right, seen more prominent along the sternal border. Right, so that is what is called as the EART second sign. So if you see this question now, EART second sign, it is a large pericardial effusion that makes the left first rib seen more prominent along the sternal border, and that suggests almost like massive pericardial effusion. Okay, so because of the presence of the pericardial effusion, this left first rib, it becomes more prominent along the sternal border. Next, now we have one classical finding on percussion in case of pericardial effusion, that is called as the Dressler sound. The Dressler sound in pericardial effusion is flat sound on percussion, the upper half or 2/3 of the sternum, flat sound on percussion, the lower half or 1/3 of the sternum, flat sound on percussion, the lower half or 2/3 of the sternum, flat sound on percussion, the upper 1/3 of the sternum. Now what is the Dressler sound? So we have Dressler sign or the Dressler sound. So if you take the Dressler sign, the same, right, more or less the same. So the Dressler sign or the Dressler sound, it is a flat sound on percussion of the lower half, right, on percussion of the lower half or 2/3 of the sternum. That is what is called as the Dressler sound, right? It's a flat sound on percussing the lower half or 2/3 of the sternum. Next, then followed by the Dressler sound, next we have the Bamberger sign. So if you take the Bamberger sign, it is the dullness at the angle of scapula. What did we discuss just now? We have just now discussed that the angle of the scapula, that is just below the angle of the scapula, you have the presence of egophony and as well as the bronchial breathing. Now what is that particular sign where you have the presence of the egophony and as well as the bronchial breathing? So that particular sign is the EART sign. Now what is this Bamberger sign? This Bamberger sign is nothing but it is like the disappearance of the EART sign. See, what you have to do is, in the EART sign you have the egophony and as well as the bronchial breathing. Why is that? That is because the lung is being compressed. And when you percuss that area, you will have dullness. And this particular dullness, right, this particular dullness at the angle of scapula, right, this particular dullness at the angle of scapula, it disappears. Right, dullness at the angle of the scapula disappears when the patient lean forwards. Right, when the patient lean forwards, the dullness at the angle of the scapula will disappear. Why? Because once the patient leans forward, the pericardial effusion fluid, which is compressing the lung parenchyma, will disappear. Thereby, the dullness also disappear. That is what is called as the Bamberger sign. Next, followed by that, the next important sign is the corner sign. See, what is this corner sign? Dullness at the left lower lung field is EART sign of pericardial effusion, while the same dullness on the right side. So, right sided lower lung field dullness. Right sided lower lung field dullness is called as the corner sign, whereas left sided lower lung field dullness is EART sign of pericardial effusion, whereas right sided dullness, it is the corner sign. So please remember these two dullnesses: left lower lung field dullness, EART; right lower lung field dullness, that is the corner sign. And why is that? That is because the pericardial effusion fluid is compressing the lung parenchyma, and that is what is nothing but your dull note why you are getting. Now, whenever there is disappearance, what is Bamberger sign now? Bamberger sign is disappearance of EARTs or corner sign when patient sits up and lean forward. So, disappearance of EARTs and corner sign when patient, right, when patient sits up and lean forward. Right, when patient sits up and leans forward, that is what is called as the Bamberger sign of the pericardial effusion. Now these are all the various signs of the pericardial effusion. So to summarize all the signs of pericardial effusion, right, we have started the signs from the Friedrichs. So what is Friedrichs? Sudden collapse in the distended neck veins with diastole. Next, Onbrugger's. What is Onbrugger's? It is an epicardial bulging due to massive pericardial effusion, and whenever you compress, there will be hemodynamic compromise and cardiac tamponade. Then we have discussed Pitrus. Pitrus is the anterior bulging of the lower sternum that suggests the pericardial effusion. Then we have the Sansom sign. Sansom sign, the percussible dullness in the left third intercostal space suggests the large pericardial effusion. Then we have the green sign. Green sign is lateral displacement of the percussed cardiac border with expiration suggests a large pericardial effusion. Then followed by that we have Epstein sign. Epstein sign is a large pericardial effusion can blunt the percussible right cardiomyopathic angle, producing dullness along the lower right sternal border. That is called the Epstein sign. Then we have the Roth sign. What is Roth sign? Dullness at the right lower sternal border suggests the large pericardial effusion. Then Moshovitz sign. In pericardial effusion, the transition on percussion from the lungs in the right heart border is abrupt. That is called the Moshovitz sign. Then we have discussed about the EART sign. A large pericardial effusion will produce egophony and bronchial breathing at the lower border of the left scapula, or even there can be percussible dullness in the same area. Then followed by that we have discussed EART second sign. EART second sign is a large pericardial effusion makes the first strip seen more prominent along the sternal border. Then Dressler sound, right? What is this particular Dressler sound? It is a flat sound on percussion of the lower half or 2/3 of the sternum. Then we have the Bamberger sign, that is the dullness at the angle of the scapula that disappears when patient lean forward is the Bamberger sign of pericardial effusion. Then we have the corner sign. Dullness at the left lower lung field is EART sign of pericardial effusion, while the same dullness on the right side is the corner sign. And the disappearance of EARTs or corner sign when patient sits up and lean forward is the Bamberger sign of pericardial effusion. Now, coming to the diagnosis. So, how will you diagnose? Echocardiography is the most effective laboratory technique available. So, echocardiography. Right? So, this will be the important investigation that will confirm the presence of the pericardial effusion. Even minimal pericardial effusion can be made out by echocardiography, right? So, you can see this. Now, this will be apical 4-chamber view. So, in the apical 4-chamber view, right, you can make out the presence of the fluid in the pericardial space. Then, this will be the lateral view. Right, this will be the lateral view, and you can make out here the presence of the pericardial fluid, right. So, the presence of the pericardial fluid is recorded as a relatively echo-free space between the posterior pericardium and posterior left ventricular epicardium, right. It is being represented as the echo-free space. Right. So, that will be the pericardial effusion. Now, followed by that, the chest X-ray. Another important investigation is the chest X-ray. In patients with large pericardial effusion, the heart may swing freely in the pericardial space, and this motion may be associated with electrical alternance in the ECG. But the chest X-ray, it will show the presence of a water bottle configuration. That means there will be a cardiomegaly, right? There will be cardiomegaly, and this cardiomegaly on the chest X-ray, it will show as a water bottle configuration. Right, it will be seen as the water bottle configuration, and I'll just show you that. Yes, so this is what is your money bag appearance or water bottle configuration. And if you see the pedicle, right, if you see the pedicle, you have the presence of a narrow vascular pedicle. And what will happen to the cardiothoracic ratio, right, that we call it as CT ratio. Normal CT ratio is, right, normal CT ratio is 0.5, but here the cardiothoracic ratio will be elevated. That is what is the chest X-ray picture in patients with the pericardial effusion. Then, so this is, yes, so this is another X-ray suggestive of the pericardial effusion. Then followed by that, the ECG. In case of massive pericardial effusion, you have the presence of what is called as low voltage complexes. Right, presence of low voltage complexes. Now what is the criteria for low voltage complexes? That is, the amplitude of the QRS complex will be less than 5 mm in limb leads, whereas the amplitude of the chest leads will be less than 10 mm in the precordial leads or in the chest leads. That is what you will see in the massive pericardial effusion. And what are the other conditions where you have the presence of low voltage complexes? These low voltage complexes are also seen in clinical scenarios like the restrictive cardiomyopathy. This low voltage complexes also seen in patients with constrictive pericarditis, right? And these low voltage complexes are also seen in these patients with the pericardial effusion. Whereas you take in case of cardiac tamponade, in cardiac tamponade, the ECG, it will show you the presence of the electrical alternance, right? It will show you the presence of the electrical alternance. What is electrical alternance? Electrical alternance is that where you have one complex being large and the alternative complex being small. So one complex is large, the alternate complex is small. One complex is large, the alternate complex is small. That is called as the electrical alternance, right? Then followed by that, what will be the treatment in these patients with the pericardial effusion? The treatment is the aspiration of the fluid. Right, the fluid aspiration, and after the fluid aspiration you have to send it for diagnostic purpose. So when you send it for the diagnostic purpose, that will evaluate and tell you what is the cause for the pericardial effusion, and accordingly you can treat the underlying cause. Right, accordingly you can treat the underlying cause. Okay, so that is about the treatment of the pericardial effusion. So in the pericardial effusion you need to know what are the etiologies which will cause pericardial effusion, and if you take the hemodynamics, what exactly are the clinical manifestation that you will see is mainly the dyspnea, that is because of decreased filling into the ventricles, and along with that they will also have fatigue because of decrease in cardiac output. That will be the clinical manifestations, dyspnea and as well as the fatigue. And regarding the signs, already I have taught you, we have many signs that you have to elicit in pericardial effusion and as well as cardiac tamponade, and the best investigative procedure will be the 2D echo. The treatment is the fluid aspiration and treat the underlying cause. Thank you very much.